So Sandhya, Moffitt Cancer Center, wonderful member of Sandy's lab, please.
Thank you, Joe. Hello, everybody. I'm Sandhya Prabhakaran, and I'm here today to present about evolutionary immunotherapy in non-small cell lung cancer. And can we identify dosing strategies that are optimal in adoptive cell therapies using agent-based models? So this is a huge collaborative effort between multiple departments at Moffitt, and I'm very grateful for the opportunity, one, to be part of the project and also to be able to present the work here. Okay, so what's the motivation? We do know that immunotherapy has shown success in many cancers, but not so much in non-small cell cancer, and the fact that not all patients respond the same way to this treatment. And this could be because of the complexity of the tumor immune ecosystem and the intra-tumor heterogeneity. So there is this emerging immunotherapy called adoptive cell therapies or TIL therapies, where activated T cells are injected into the patient. And this therapy is not foolproof. It also fails because of tumor-induced immunosuppression, for example, that's posed by the PD-L1, PD-1 axis. So while high PD-L1 expression on tumor cells is often associated with strong immune response, the impact of time, specifically the duration, the frequency of the treatment to strike the tumor, these are all very important. And I also wanted to highlight that there were many talks across these past days, especially from today's talk by Dr. Rob Noble, Galit Lahab, Einar, Maxi, Luciana, Nicholas. There's so many people who spoke about the importance of timing of treatments across different cancers. So I hope that in today's talk, we are able to present a framework, an agent-based modeling framework, in which we are able to address at least half or some of those questions to some certain extent. And therefore, it's very important, seeing the importance of the problem, that one has to understand the tumor microenvironment and all these resistance mechanisms to be able to help shape optimal treatment strategies and to improve the impact of adoptive cell therapies, specifically in this case for non-small cell lung cancer. So to start off, there was a model that Mark and Sandy had built a few years back. It's an ODE model. If you look at the figure here, so let's say we have two compartments, the tumor compartment and the immune compartment, along with the immunosuppression that's given by this vortex. We have equations over here, and assume that when we clear this out, we get what you see over here. The blue arrows that you see are the immune strikes, so the times when the immune strikes the tumor. The red curve shows the tumor burden, and the green shows the immunosuppression. So here you can see the tumor escapes. And if you space out the immune strikes a bit farther away, you can see that the tumor can now be eradicated. And if you space out the immune strikes a bit more farther, you find that now you can actually suppress the tumor, but then it eventually grows. So now you're in a state of equilibrium. So what this says is that what the ODE model shows was that there is an optimal spacing that's out there, in which you can, if you use the T cell as pulses, you can get tumor extinction. So the question was, or what we were trying to identify is, can we understand these complex dynamics in the tumor immune microenvironment and see that can we maximize tumor kill by minimizing immune suppression? So what we did was we used a mix of in vitro studies as well as map modeling to see if we can answer and better understand this complex dynamics. So as always, we need assumptions. And I'll just quickly go over the sketch that you see here. We have two compartments, the T cell compartment and the tumor compartment. The T cells are again divided into active and inactive T cells. Active T cells produce interferon gamma. And the tumor cells are again divided into two, those that are high in PD-L1, meaning they are resistant to treatment, and those that are low in PD-L1, so they're sensitive. And the ones that are resistant can go ahead and also deactivate the T cells. So this feed-forward feedback loop is actually incorporated in our agent-based model. And how we actually calibrated that was by, initially, we do have experimental data for this. And as of yesterday, we did get a huge load of data that I have to start looking into. So big thanks to Bob Gatenby and Kim Luddy for sharing that. So we initially had coded this as a pulse. So In a petri dish, we had tumor cells seeded, and they were hit with interferon gamma. Remember, this is what is secreted by the T cells. And these are now coded as a pulse. And then we went ahead and actually also coded that in the agent-based model as a separate grid. And I will go into the grid in a bit. So you can see here, these are the agent-based model grids that you see. This is for the tumor, and this is for the immune cells. And this is a snapshot of the data that we have, that we use to actually calibrate the agent-based model. I'm happy to go into this if time permits. And how we've designed the agent-based model is that we've looked at different spatial configurations of the tumor. And this is, again, inspiration from one of Jill's papers, where they looked at a circular setting. So the tumor can be seeded as a cluster, and then the T cells, the blood vessels are around it, meaning it's a necrotic core. That's an abstraction of the blood vessels. And then we have another setting where the tumors are again seeded as a cluster, but it's nicely embedded with blood vessels. So it's a fairly new tumor core. And then we have randomly seeded tumor cells as well as immune cells. So each row over here actually shows the different agent-based model in the grid. And each column here now shows a spatial configuration. Play out, the last row is actually showing the interferon gamma. That's actually a PDE grid. These are different rules. The tumor cells can initialize to be either random or cluster seeded. They can divide, move, or die. They have two states, up and down. I'm happy to go through those as well, but I don't know if I have time. And the PDL1 expression, the up and down regulation is given by the sigmoid function. T cells, like I said, they can be either at the periphery of the tumor or they can be seeded randomly. And they can be in two states, active and inactive. And active T cells produce interferon gamma, and interferon is a diffusible. That's given by this equation shown here. This is the flow chart of how these different interactions work, and we have calibrated the different hits and the percentages from literature as well as the data that we've obtained experimentally. And as we know, we have a lot of freedom with agent-based models, in that now you can even tune various knobs and see how the model comes up with results. So this is what I call as a simulation tree. In the first row, you find the different spatial configurations that one can use: the random, the cluster setting with rich blood vessels, and the cluster seeded with poor blood vessels. You can also initialize the tumor with 10% of the grid size, 50% or 100%. Then the different days in which you can strike the tumor. So it's from 1 day, which is daily and not possible, to I think 500 for now. And then the strength of the T cells. So how many T cells do you want in that one hit? And how strong is the interferon gamma signal? So we've actually been able to play our way through each of these different layers. And every time we run that, we can see that we get very interesting results. Okay, so this is just a snapshot of, like, I have some GIFs here. So basically the rows would be the different spatial configurations. And the first column would be that of the tumor cell with the PDL1 expression, second column with the T cells, and the third column with the interferon gamma. So it seems it's already started at 17 days, but okay. And over here, what I wanted to show is we are able to achieve escape, equilibrium, and extinction. So first, second, and third columns here. The black curve is the tumor growth. And you can see the T cells, the purple lines actually chasing the tumor in each of these conditions. The red line is when you started. So every time you go above, the tumor goes above that, we call it as an escape. If the tumor is below the red line, then it's an equilibrium. And if it's eradicated, it's an extinction. So this is just to play out the different knobs that you turn and at what condition you're able to get these different simulations. So of course, we can't have this in a paper. So this is a flattened out version of what you actually saw on the last slide. This escape is the first panel, equilibrium in the second, and extinction in the last. And he's showing in the first half of that what happens, or how the grid looks like in the first 20 days and in the last 50 days. I also wanted to show a few more slides on the results. So for example, here, what you see in these subpanels are 3 different spatial configurations. And each grid over here is actually a summary, an average of 10 different simulations. So the first row, you have the tumor grid initialized to 100%, so it's at confluence, and you hit the tumor every day. So the columns are the dose schedules, and the rows would be by how much have you initialized the tumor, and then you play this out. So the black curves that you see here are the average of the tumor growth, and the colors are what we're interested in. Anything that is in blue means it's an equilibrium situation, and anything in green means it's an extinction. So what we'd like to identify, do we have these Goldilocks or optimal zones when we run these or when we play this agent-based model of settings that you see here in the simulation tree. And another test that we did was just, we can do a lot. What we've done here is, in this particular experiment, trying to adjust or see the strength of interferon gamma that exists in the system. And again, we can see that we have these patches of blues and greens, which is what we really need. So it does indicate that there are these optimal windows that we can strike into. And this is very informative for understanding what the next kind of treatment should be for the patient. And so there is the cyclical nature of PD-L1 that we would like to really understand, because that's what gives these effective treatment windows. We've seen that timing matters, the spatial configuration matters, the tumor burden at the beginning matters, because these are all non-linear relationships. There are spatial effects, and interim treatment is better than continuous treatment. And right now what we're doing is we're trying to explore like treatment holidays, dynamic treatment holidays. And I wanted to mention that haven't been able to achieve Heiko's razor because this agent-based model is definitely more than 2 parameters. But it's a nice, decent starting point from which we can layer up and leverage for various studies in the future. So it's clearly a signature for simple and evocative model. And yeah, so this is just a graphical model of what I said. If you haven't followed the talk, basically we have some input data, we have this agent-based model that we've built, and we're able to realize the effects of different conditions to achieve tumor escape, equilibrium, and extinction. And with that, I'd like to thank this huge and amazing team that I'm part of, Sandy, Bob Gatenby, Amar, Janelle, and Scott. And yeah, thank you for the opportunity and for your time.
Howdy, while we're getting the next speakers set up, any questions?
Great talk, thank you. In your in vitro system, did you actually pre-activate your T cells, or did you use naive T cells?
So in the experimental studies, we do not have T cells. We just had interferon gamma as a stimulus that was injected for 2 days. So they played the cells and then they...
Oh, you did not add?
So we did not. And because we have the flexibility of an agent-based model, we were like, okay, let's make our lives harder. So we had another grid that was specifically meant for T cells. And now the active T cells produce interferon gamma. So the experimental data did not have.
Okay.
Thank you.
Thank you.
Hey, Sandhya.
Yes, hi.
So you want to do that for non-small cell lung cancer, is that right?
The cell lines that were used, yes, is not small.
So from the clinical side, it looks like your results are quite heavily dependent on the spatial configuration of these tumor cells, right? Everything random, you could easily eradicate that. Once you had clustering, it was more difficult to eradicate. So do you know in patients, if you look at biopsies, what does the clustering, what does the architecture of these tumors look like compared to those?
I think that's a great question, Heiko. So we're still in this part of the project where we just receive or are receiving the data. I don't want to say that being in the random setting never led to eradication. We do have conditions in which even the random setting has tumor growth. Sorry. It was the most successful, yes, but there are also conditions in which you have the random also evolving. But connecting that to clinical data is definitely something we should be doing, but we haven't done that yet. Awesome. Thank you.
Sandhya, thank you very, very much.
Thank you very